Abhishek, unmute yourself.
Sorry. Now I'm audible?
Yes.
Yeah.
Very much.
Good evening, everyone. My name is Dr. Abhishek Vidyadhar Lunikar, and I'm consultant anesthesiologist at Sancheti Hospital, Pune. Today's my topic of webinar is landmark guided caudal anesthesia. Caudal anesthesia is very well-known technique and is practiced widely all over the world. It is one of the most commonly used central neuraxial blockade technique in pediatric patients. Just a minute. It's not moving. Yeah. In 1933, Meredith Campbell, a urologist from United Kingdom, first reported use of caudal anesthesia for cystoscopies in children, which involves placing of needle through the sacral hiatus to deliver medications into the epidural space. It is used for surgical anesthesia and analgesia in pediatric patients, but also a popular technique which is widely used for chronic pain management in adults. Generally used drugs for caudal anesthesia are bupivacaine, levobupivacaine, and ropivacaine. As already stated, it is most commonly used technique in pediatric regional central neuraxial blockade, used as an adjunct to the general anesthesia in pediatric cases, also as a part of multimodal postoperative pain management, and is used as a single shot technique in minor procedures. Also, it has been found a use in obstetric analgesia for second stage of labor or instrumental deliveries. But I have specifically mentioned a note of caution in red, which is a care should be taken while injecting the drug as fetal head lies close to the site of injection, and there is high risk of injecting local anesthetic into the fetus. It is used in adults for chronic pain problems in leg, mainly after collapse of intervertebral disc or post shingles below for pain below umbilicus. Contraindications. Contraindications for caudal anesthesia are infection at the site, pilonidal sinus, coagulopathies, and congenital anomaly of spine or meninges like meningocele, meningomyelocele, or T-third cord. Anatomy. Now, first of all, for going for caudal, we have to first understand the anatomy of the caudal anesthesia. Caudal anesthesia, as you can see on the image on the left side of the screen, is a patient or a pediatric patient lying in a lateral position, in which there is a marking of posterior superior iliac spine, iliac crest, and sacral cornu. If we see, we can neatly point out that it forms posterior superior iliac spine and sacral cornu forms equilateral triangle. But if you go on a sacrum, actually, we have to enter the sacral hiatus, while posterior superior iliac spine lies near superior lateral sacral crest. Anatomy in children. Now, the diagram on the right side is very famous. Everybody knows that diagram, but what are its anesthetic implications? There are differences in the spine of pediatric patients as well as adults. What differences are also important to know before going for caudal anesthesia. First of all is lower termination of spinal cord at the level of L3 and L4. It causes, the anesthetic implications are increased risk of direct trauma to the spinal cord. Thus, we have to avoid any epidural approaches above L3. Another difference is lower projection of dural sac at S3 and S4. Because of this, there are high chances of inadvertent penetration of dura mater while going for caudal anesthesia. While another difference is delayed myelination of nerve fibers. It adds a plus point of easier intraneural penetration of local anesthetic, while onset time is shortened and thus helps with diluted local anesthetic, which has got the same effect as that of a concentrated anesthetic drug. Some other changes or differences in the pediatric spine are spinal curvatures are not well developed or not developed at all at birth. Because of this, like cervical lordosis develops at around 6 to 3 months, lumbar lordosis develops at around 8 to 9 months. Due to these, we can thread a catheter even up to the caudal catheter even up to the thoracic level in the neonates via caudal space. For epidurals or while going for epidural anesthesia, there is no need to adapt the needle orientation as per the spinal flexures before 6 months of age. As age increases, sacral hiatus becomes difficult to identify. One of the reasons for it is thickening of sacrococcygeal ligament, thus increasing the failure rate after 6 to 8 years of age. Also, pediatric patients have got a higher fluidity of epidural fat, thus causing better drug diffusion, and catheter can be threaded for also longer distance. This is a chart showing overall changes or differences in the pediatric spinal cord. I have pointed out the 4 main points with the red arrow, which are relevant for caudal anesthesia. First is, as earlier stated, lower projection of dural sac, causing resulting danger is increased risk of inadvertent penetration of dura mater. Thus, always check for CSF reflex, including even during caudal approaches. Then cartilaginous structures of bone and vertebrae, thus causing decreased resistance to the penetration by sharp needles. And direct trauma to the, also a drawback is a direct trauma to the bone, causing contamination of the ossification nuclei and compromising further growth or joint growth. To avoid, use a short beveled needle instead of using thin and sharp needles. Also, if you encounter any resistance while inserting a needle, please stop and change the direction. Also, as the age increases, there is change in the axis of coccyx. The sacral hiatus becomes comparatively smaller with increasing age, and ultimately the identification of sacral hiatus is more difficult after 6 to 8 years of age. And previously in previous slide, as also I have shown that increased fluidity increases diffusion of local anesthetic, thus helps in excellent blockade. Now, technique. Most commonly, it is done in a lateral position. Before giving lateral position, patient is sedated. Many of times, general anesthesia is given. If patient is fully awake, patient can be kept in a prone position, but this technique is commonly or routinely tried in infants. Now, few things we have to note is distance from skin to anterior sacral wall is approximately 2 cm. Summit of sacral hiatus and dura mater is 1 to 3 cm. Needle which is commonly used is 22 gauge hypodermic needle. Also, short stylated 2-Hz needle can be used. Landmarks. Sacral hiatus can be identified by first palpating the coccyx and then sliding the finger upwards in the cephalad direction until a depression is felt in the skin. Also, sacral hiatus is a U-shaped and V-shaped aperture due to the lack of dorsal fusion of 5th and 4th sacral vertebral arches. There also in many centers where it is routinely practiced, as it forms an equilateral triangle with PSIS, many of times after putting the patient in the lateral position, PSIS is palpated with the index and a middle finger, and thumb makes an equilateral, and thumb is kept as such, it makes an equilateral triangle with the PSIs, both the PSIs. Thus, this is another technique, a crude one, which is used in many centers. Once the sacral hiatus is identified, the area above is carefully cleaned, and under all aseptic precautions, 20 gauge short beveled needle is directed. First of all, perpendicular to the skin, and once we go in, we have to change the angle with the skin with the patient to the 45 degrees. Insert till a click or a giveaway is felt. This click is because of sacrococcygeal ligament. Redirected in the cephalad direction along the long axis of spinal canal further. Before giving any drug, please see for reflux of CSF and blood. Initially, a small amount of 2 to 4 ml of drug is injected as a test dose. Also, while injecting this drug, we should watch for formation of lump in the subcutaneous tissues or feel of resistance to the injection. Also, any systemic and also for the any systemic side effects such as arrhythmias or hypotension. If test dose does not produce any effects, then rest of the drug can be injected. Needle is removed and patient is positioned for surgery. One of the another technique for identification of caudal space is swish test. It is auscultating in the lumbar region with the needle through the caudal, while injecting the drug through the caudal needle. Another technique is electrostimulation of the puncture needle, which causes anal sphincter contraction. Swish test, this was first published in British Journal of Anesthesia, which is a modified whoosh test done by Orm and Berg in Newfield Department of Anesthetic, in which they studied in 113 children undergoing elective surgeries. During insertion of caudal block, a stethoscope was placed in the lumbar region, thus for checking absence or presence of swish note. The operator's clinical impression of successful insertion was also recorded. In that, they observed that they had got a success rate of 95.6%, of which 108, which is around 108 patients. 90, and of these 108, 98 had got a positive swish test. There was no false positive results. Calculation showed swish test has got a sensitivity of 91%, specificity of 100%, and positive predictive value of 100%. Thus, it is one of the simple and most accurate tests to detect a proper placement of needle in the caudal space and can be used for teaching new residents. Now, as I have stated that caudal catheter can be inserted or threaded through the caudal space, which can be threaded till mid-thoracic region. Usually, this technique is used for giving continuous postoperative analgesia, even intraoperative analgesics in age less than 1 year. This is done commonly under USG guidance or electrostimulation with a self-stimulating caudal catheter. Another crude technique is external measurement. Just measure from the dermatome till the caudal space distance and insert that much length. Always after caudal catheter threading, go for tunneling of catheter. It helps in avoiding displacement of the catheter, as well as it helps in contamination of the catheter. Now, what amount of drug is to be injected to block the desired dermatomes? It is very simple to note that 0.5 ml per kg of drug is enough for blocking all sacral dermatomes. 1 ml per kg is enough for sacral and lumbar dermatomes, while 1.25 ml per kg is enough for mid-thoracic levels. The most tedious part is drugs and doses. Maximum allowable doses for injection are single injection technique if used for bupivacaine, ropivacaine, and levobupivacaine. We can go for 3 mg per kg. Lignocaine, we can go for plain lignocaine 5 mg per kg. Lignocaine plus adrenaline, we can go till 7 mg per kg. If a continuous caudal infusion is used, then bupivacaine, ropivacaine, and levobupivacaine, for all these three, 0.4 to 0.5 mg per kg per hour dose is enough, while lignocaine 1.6 mg per kg per hour dose will suffice. Complications of caudal catheter are intravascular or intraosseous injection. This may lead to grand mal seizures and or cardiorespiratory arrest within a short time post the procedure. Dural puncture, and care should be taken, as if a dura puncture is done and if we didn't check for CSF reflux, then it may cause total spinal. Thus, as the drug is injected in the subarachnoid space, which causes, if the patient is under sedation or mild sedation like ketamine, which is commonly used in pediatric patients, may lead to apnea and also cause profound hypotension. Management includes control of airway and breathing, treatment of blood pressure with intravenous fluids and vasopressors such as ephedrine. Complications. Another complication is perforation of rectum. With a simple needle chances are there, but if you realize, the moment you realize that a rectum puncture is done, better to discard that needle, because if we redirect the same needle towards the caudal space, may cause infection. Also sepsis, urinary retention, and hematoma. Thank you.
Thank you, Abhishek. That
Thank you,
was
ma'am.
that was indeed a fantastic presentation, and it was really you focused on the basics of caudal epidural. So let's move ahead to the second talk, and let me again try to share my screen. Okay, Varushali, you can start sharing your screen. Let me just introduce you. Ultrasound has played an increasing role in regional anesthesia and pain management. And ultrasound guidance can be utilized to identify the sacral hiatus, thereby facilitating the needle entry as well as visualizing the needle in the caudal canal. Let me introduce you our second speaker of the day, who may be called one of the pioneers of this technique in India, Dr. Varushali Ponde. No words are required for her introduction, and if I may say, naam hi kafi hai. As you all know, she is the president, managing trustee, and founder secretary of AORA India, and has represented India on various international regional anesthesia platforms. We are privileged to have you with us today, Dr. Varushali. Over to you now.
Thank you, Bharti. At the outset, can everybody hear me and see my slides? Bharti,
Yes,
yeah.
yes, go ahead.
Yes, ma'am.
Yeah, cool. Well, Bharti, I know you are my friend, so I know flattery comes to you very natural when it comes to friends. Thank you very much for that benevolent introduction. I am indeed flattered. Well, now let's come to the most interesting topic. It's very close to my heart. That's because, well, let me complete this lecture. You shall understand why. So, we are going to look at caudal epidural blocks with or without ultrasonography. I think the previous speaker has already done half of my job, or perhaps completed my job of the without ultrasound aspect. But we are going to ponder into preterm neonates, infants, toddlers, and of course grown up kids. So let's really dig deep into caudal epidural, because very seldom, please listen to this, very seldom you get a chance to take just one block, focus in the details of it, and then come out of it with your own thoughts. And this is what is going to happen to all of us at the end of this webinar. So I really am very happy that such a time is being given to something so important as caudal epidural. When it comes to webinar, I always feel it's kind of a monologue. You know, you keep talking to your own self. You project your thoughts, and then you are constantly looking at what you already know and what you have learned, and perhaps what is the correct way to go ahead. Bharti has just said that yes, ultrasound has been introduced, but at the same time, I also know that it has been a block which has been there for decades. We all shall agree on it, because of just one factor. It's extremely simple. It's a smart block. It's an impeccable technique, immaculate, very simple. Abhishek has just shown that to you. The method can be very well deciphered by everyone. There are lots and lots of publications to support it. The learning curve is fantastically small, even 30 caudals, and you can really know how to give caudal. And you need very few equipments. So yes, it indeed is a very, very simple technique. And now we are going to apply ultrasound. So are we really justified, and what does it really add? We are going to really think deep over this. As he said, this is how a simple caudal epidural will be given. Look, make an equilateral triangle. It's no longer an equilateral triangle, but yes, palpate the sacral corner. The needle may look long, but how much to insert inside is in your hands. Get the give of sacrococcygeal ligament, aspirate and inject your drug. As simple as that. Now, what could go wrong? Abhishek has told us that it could go inside the sacral floor itself. So it is as good as an atrocious injection. Disaster. It could go through the sacrum. it is in the rectum, disaster. It could go in the dural sac. So the dose calculated for caudal epidural now goes in the dural sac, disaster. The last and the most important one is if it is in the subcutaneous place, you get a failed block, bigger disaster for an ego of the anesthesiologist who wants to learn caudal. So these are the things that can go wrong with something as simple as that. Now, do we have a foolproof answer? Having said this, I know that the success rate of landmark guided caudal is extremely good. We just saw the journal article he quoted. It was way long back and it's quoting 95%, which is an excellent rate. But when complications happen, I think it's 100% complications. So let's look at it. What could go wrong? We pondered on that. Let's take another modality here, the peripheral nerve stimulator. He did say that we have peripheral nerve stimulator. So now let's see what he really meant. What he was trying to tell us was, instead of a 22 gauge caudal, pick up a PNS needle and start giving it with a very high current amperage. It should be at least 3 to begin with. Take the same landmark, just change the needle. Once you get the give, you increase the amperage and see for the anal contractions. It will very often happen that you may have to introduce the needle little further, that you really touch the big motor nerves in the phylum terminal. Number one, because these nerves are very very big, you need a bigger current to stimulate and get the end motor response. What has this modality really answered us? It has answered us one question: it's not in the subcutaneous plate. You wouldn't get a response. Number two, it has also answered us that it is indeed lying in the phylum terminal and not inside the dural sac. If it was in the dural sac, you would get a contraction even at zero. 0.2 or zero. 0.1 milliamperes. So that really rules out injection inside the dural sac itself. So that's one thing PNS has really answered. Perhaps PNS hasn't answered us how far does the drug go when you calculate giving the Armitage formula. Having said this, let's look at the downside of it. You pick up a PNS needle, which is costlier than the BD needle or a hypodermic needle. And you can never ETO a PNS needle for at least the central neuroaxial block. So that's the downside. But you are most welcome to do this. Now, coming to ultrasound, you can first let us dwell into the equipments. Ultrasound shall be bought for many reasons, and caudal epidural would be one of them. You can use a swanky hockey stick probe with a very small footprint, but it's expensive. It's all right if you don't have it. You can use a simple high frequency linear probe, which will in fact show you many spines at the same time. So your vision in fact is broader through the skin. Now, if you really want to look deep into the longitudinal section, lots of answers would be found, including the spread inside the neuroaxial conduit, which shall be as follows. So let us look at it extremely carefully. For that, I would want you to get oriented to the scan that I am showing you. This is the longitudinal section as such. We must know where the orientation marker is, which is towards the caudal end of the patient. You could keep it at the cephalad end as well, as long as you're mindful of where the orientation marker is. So this is your skin, or rather the patient's skin and subcute. Having said that, you would have by now realized that this is the posterior of the body and this is the anterior of the body. So this is the skin and subcutaneous tissue, remarkably thin, and these are the sacral spines. Go back to Abhijit's lecture. What did he say? They aren't ossified as such in very small babies. If they aren't ossified, they're not going to cast a shadow. And here you see a very well-defined phylum terminal. So this is the roof of the caudal space. this is the content of the caudal space, and this is the floor of the caudal space, which is the base of the sacrum. So the roof, the content, and the floor is right in front of you. Now slide the probe a little more cephaloid, and you are actually going to see the conus if you're too cephaloid, or you are going to see the dural sac even before that. We are going to see the dural sac as well as conus immediately in a preterm or a very small neonate, because a high frequency linear probe is going to at least show those many spinal levels for you. So this is the dural sac, if you can appreciate. So these are all the sacral spines, these are the sacral vertebrae, and this is the phylum terminal here, and this is the dural sac. I can very conveniently call this as the posterior dura. I could call this the anterior dura. I could conveniently call this the ligamentum flavum. However, I'm not 100% sure of it, but yes, I can, because it's a very small baby and I can even see the epidural space, which is in between the posterior dura and the ligamentum flavum. So these are the spines, this is the ligamentum flavum, and this is the posterior dura. If I want to be politically correct, I am going to call the entire thing as the posterior dural complex. If I come on the anterior aspect, it's the same story again. This is the anterior dura, and this is the posterior aspect of the vertebral body. So together, they are going to form anterior dural complex. So this is in nutshell what is the longitudinal scan. Now what I'm going to do is I'm just going to shift a bit here, and I'm going to show you the conus medullaris. Now come a little more ahead, and now we are in the in the junction of the sacral and the lumbar region, and you will see the conus medullaris. So be very vigilant here, and this is the true spinal cord. So this is the posterior dura, that's the anterior dura. These are all the phylum terminal originating here. You could see, if you really scan a little ahead, you will even see the central glial tissues. So caudal epidural, if you understand this concept with the vividity of what it is like, you will really understand what dosages you need to pick up, at what level you need to do what in the central neuroaxis of a baby. And then, of course, as they grow, the situation is going to change, and we shall soon see how, because it's an extremely interesting story to tell you. Now, let's come to what addition longitudinal axis really give you. You go back to Abhijit's lecture, he said, yes, go ahead, keep the stethoscope and hear this gurgle of the fluid that has been injected in the central neuroaxis. That's nothing else but this, that's the test. Now you will really see the drug seeping up, and you probably are going to, not probably, you are going to be very sure of the vertebral level if you have really calculated the levels correctly, because sacrum, you can't mistake, you've just seen it. The lumbar vertebrae, when they start, you can't mistake, you have just seen how they look. So go ahead, keep your probe at T10 if you want to do a hernia, and see to it that your drug really reaches that level. And then there is no way that the surgeon will take an incision and you will get a tachycardia. Not you, your patient will get a tachycardia, provided the soakage time which the caudal block really deserves is given. Now that seldom happens in pediatric surgery, because pediatric surgeons don't scrub much. They just paint by two solutions, betadine and then sterilium at the most, and take their incision. They're fast in getting prepared to take the incision. Unlike orthopedic surgeons, they take time, they scrub, they paint, they drape, and 20 to 15 minutes soakage time in a grown-up kid is always given. Neonates, yes, they too take at least 3 to 4 minutes. So give the drug, make the child supine, and he is ready for incision. No, that's not so. So please do take allowances if at all you haven't given the soakage time. So these are the practical tips and tricks that really come to your mind after taking a lot of setbacks and seeing what has gone wrong. When you see you have given a proper block and it hasn't acted, you must know why. Just in case, As a regional anesthesiologist, if you have become very, very curious as to, yes, my drug was given well, so why was the tachycardia? And if you have done the soakage time interval also correctly, then at the end of the surgery, if you want to ensure that it was at the level or was I totally wrong, gently pinch the kiddo uh, on the legs. If he moves the legs, you are out of the caudal space. If he moves, he doesn't move the leg, but he moves the legs, tries to move the leg, maybe at the inguinal area and above, then maybe the level was not sufficient. So you can give answers to yourself in very many manners to be very sure that your drug has acted and it was given where it should be. So coming back, I sorry I took a detour because I think that was necessary. And now coming back again to the central neuro axis, and let us see how the drug can be seen in the conduit as such. Now, how do we see it is this way. We already saw that this is the posterior and that's the anterior. Now, this is the sacral spine. I know in adults or in grown-up children, you are going to take a paraspinal view, and then you're going to tilt the probe as if the ultrasound beam is going to enter inside the spine. So that may not be done in very small kids because, as I told you, the spines are unossified, and you're going to see it straight from the midline itself. So if these are the spines, those who are acquainted with ultrasound spine will realize that they are spines and they are not lamines. Lamines will be slanting. So these are the spines, that's the posterior dura, and the drug has, kind of made its own way and has settled here. This is the ligamentum flavum, this is the posterior dura, and this is the unequivocal pitch dark anechoic drug sitting in the neuroaxial conduit of a baby. So this is how you will really understand that you have reached where you wanted to reach. It's kind of a surrogate marker. So this is what ultrasound is adding on. Now, uh, I am always fond of looking at dynamic scans first before we go to the the statics, or rather let's do the other way around as well. So look, this is the static scan. Let it soak in your mind very well so you pick up the video well. Posterior dura, anterior dura, this is the central glial tissue, and this is the drug that has been settled. Now let us come to the dynamic scanning, and this is how it goes. Sorry, I am going to off the voice and I'm going to talk to you all about it. Now, this is the caudal end, and that's the cephalad end. That's the posterior. You will see the needle coming in right here, and can you see the needle coming right here? But look what has happened now. The needle is far too close to to the dural sac. Now, this is how you can see how your residents are doing, or let them know what they are doing. Or sometimes it can be even us when we do it, because sometimes the dural sacs can be lower than what we expect them to be, especially in very small babies. So what would you do? You withdraw the needle and inject the drug again. Okay, so this, due to the previous injection done, some amount of drug has already gone inside, and the air in the hub has also kind of entered into the epidural spaces. We shall anyway see this phenomenon again. Look at this one. This is the seeping of the drug, as it were, in the central neuro axis. So this is how it will go ahead. Now we are almost in the anterior dura. Withdraw the needle. And this is the drug which has finally made its way. This is a bigger baby. You don't even see the dural sac. You will see the needle. You're far more comfortable in this scan. There is no dural sac at all seen. It's far ahead. So this is what happens when children grow. And you will see the seep here. You will see the posterior dura and anterior dura coming towards each other, and the drug making its way ahead. So this is how the distributions happen. And if you keep your probe exactly at a point where you want the drug to go, maybe T10, then you should be able to see the fall of this particular dura, as you can see it here. If you have the time and in the inclination, you can put this up. There is no way that this can relinquish our conventional attitude of giving caudal, because even candidly, even I do practice very quick landmark guided. But if the probe is already there, I would love to put basilol spray on it, just hold it a bit away while the prick has already been taken and see what's happening inside the central neuroaxis, because I just get curious. Now, if you are with me in this, on the same page all this time, then look at this one. Where is the needle, you think? How I wish I was live with you. The needle is right inside the subcutaneous plane. If you give an injection here, the block is going to fail. So this is what ultrasound again opens up. Now coming to transverse scan. If longitudinal scan tells you the entire story of what's happening in the drug after it is injected, the transverse scan is going to tell you where to take the puncture point. Now let's see how. This is how the probe shall be kept, and this is how the needle shall be kept. Why have I kept the needle here? Maybe cheekily, I have already palpated the sacral cornu and kept the needle there. Yes, you could do that to begin with. Or you can be a Puritan and go through the ultrasound image itself. Now, how do you do that? It's going to be something like this. This is a grown-up kid. Hence, hence it's going to look like this. Now, let me read the whole scan for you. Posterior of the body, anterior of the body. We have used a curvilinear probe because this is really an adolescent. Now, this is the skin subcutaneous tissue. These are the two sacral cornus. Why? Why am I calling them so? That's because it's very simple. Sacral cornus are bones. Bones are going to be very hyperechoic, but there are many things that are hyperechoic, but bones would cast a shadow underneath them, and hence they are sacral cornus. Now, this is the base of the sacrum, and this is the sacrococcygeal ligament. And between the sacrococcygeal ligament and the base of the sacrum is the potential space that we are going to actually dilate by putting our drug there. Now, let's see a baby's scan. Can you see the difference now? The depth is hardly 2.7 centimeters on the screen of ultrasound. I can even reduce it further. Now see how well the sacral corners are seen. You can actually see the sacrococcygeal ligament as well. And you can see the base of the sacrum. Here is some amount of drug which has already been injected. And here is the out of plane needle entry which has left its mark. So this is what happened. This is the story of transverse axis. It's going to tell you that this is the point through which the needle shall be inserted, and it is going to tell you, or rather show you, the puncture of the sacrococcygeal ligament. An astute anesthesiologist would see it as well as feel it, and those who are proficient in giving caudal will know what I mean. Now, where is ultrasound not helping us, and where is it really helping us? Even today, we might get this kind of a stuff. We put our needle here and we get this. Ultrasound is somehow, at least in my practice, has not really answered me that here is a blood vessel, you better not put your needle. Well, in brachial plexus it has, but in caudal it hasn't, to at least my satisfaction. But if I see a dimple here, and if I see that suppose if it was not ultrasound guided days, I would still feel, okay, there is a cornu, let's go and try, and probably this would happen. So yes, this is a dimple, but I need the caudal block. It's a bilateral lower limb case. Now let's see, there is a chance of it being a thyroid cord. So this is what it goes to. Now, what I can do is, if I really get CSF coming out, suppose if I do, okay, or blood tinged CSF, I might use this as a spinal and leave it at that. But I have my reasons for not using spinal here. So if I had an ultrasound, I would scan it and I would see where the dural sac is, and I would work in accordance to that. So this formed our basis of writing this to first ourselves, and then we took a lot of pleasure in publishing it. So if we encounter something like that, we see a cyst and we know it's just a cyst and not going to bother us much, we could circumvent and do our caudal. And if we are not sure, we would just not do a caudal and we would do some other thing, because there are so many plethora of options that we have. So yes, you will have to think, you will have to see what can best be done. But one thing is for sure, every surgery could be and should be given a regional anesthesia technique simply because it's one of the best modalities or tools we have to give perioperative analgesia. I just don't mean intra-op, I mean post-op as well. Coming to the catheters that can be passed through the caudal space. Well, the portal is fantastic. From here, you can pass the catheter in neonates. Please go back to the fundamental lecture. He said that it is so open for catheter insertions. And so in good old days, and even now, we do measure actually. So if it's 15 centimeters, it's 13 centimeters in accordance to the surgical level and the dermatomes of it. So well, that much is the catheter we could put. In good old days, yes, we did it with 18 gauge. I know you're seeing an 18 gauge. You can use 20, you can use 19, and 19 is the best one to use for a caudal in a neonate. Having said this, let us see what else that has happened underneath it. If it was a traditional caudal, this is this is how it would go. We would just give a caudal. Simple that the needle is different. Simply give your caudal. Dilate the space a little. Never forget that, because that's going to aid the catheter insertion. Please be kind to yourself. Use an introducer. It makes your life easier. And then whatever you have measured, put that much of drug in, that much of catheter inside. Let it pass through, say 1 or 2 centimeters, maybe one at least, because that's the length the needle is going to take inside from the skin to the sacrococcygeal ligament. So, and then tunnel the catheter if you wish to, but I think tunneling is a good idea. Now, again, let's come to generation 2. Generation 2 is, yes, people came out and said, let's give stimulation guided. Well, at the outset, again, let me be very, very clear. We should have kept a plastic drape on the baby. But since I wanted you all to appreciate a well contracted, the soft tissues around, I am going to show it to you very bare. I start the video for you. And once we use this, you can get the sacral stimulations, then you can get the lumbar stimulations, then you can get the abdominal wall stimulations, so on and so forth. Mind you, when you get the abdominal wall stimulations, you are already in the T10 level at least. But then, if those who are practicing pediatric anesthesia will vibe with me to open a 3000 or 4000 catheter set, a stimulating catheter set, just doesn't fit in the practicality of it. If I was to use a stimulating catheter set, I might keep it for a twisted spine, a child with, a bit of scoliosis and who has come for a lower extremity or a hip surgery. I might keep it for that, not for this one. Because why should I? It is the central neuroaxis is going to show it to me so well under an ultrasound scan, and ultrasound is going to lie in my operation theater doing so many other jobs. So I am not pinching the pocket of the patient. Now, if I have to follow it with ultrasound, it's going to look like this. Now, be here. The story is extremely interesting. Hear it how it goes in. Then it would go up in the posterior, or it might go in the anterior as well, or you might just lose it. So they never go where you really want them to go. So this is the epidural catheter. On the posterior dura, you will see it moving. You might lose the tip, or you might see it very well. If you see it very well, you're lucky. If you don't see it very well, see the anterior epidural space. It might have gone there. If you still don't see it anywhere, put in a bit of normal saline and see if you can really witness the sag of the dura. Otherwise, please think that the catheter has gone out somewhere through the foramina. It all can happen. Or it can take a U-turn as well. Catheters really do not take the course that we want them to take. They're like teenagers, they challenge us. So, well, that was a detour again. So this is what it is. Now, this is what inspired us again to understand what is happening really on the skin when we really do catheters. And it's no news that it's going to be more accurate with ultrasound, but the news was something else, and it revealed it to ourselves that accuracy was not affected by age. 3 months, 4 months, or 6 months. Accuracy was not affected by age, and it was neither affected by the distance the catheter was expected to travel inside the epidural space when caudal portal was used. Was some news that I gave it to myself while I did that study. Now we do tunneling. We don't do always. We Let me be candid. We don't 100% do tunneling, but yes, tunneling is a good idea. I am giving you an example here of forming the dosages of infusions. We always use ropivacaine for neonates and infants, or even any continuous infusion. We do use ropivacaine these days because the pharmacokinetics and dynamics are best suited. Lumbar epidural, well, I know this is not the topic today, but I would just want you to have a glimpse of it. This is LOR, and we generally put it by saline. Let me tell you, in 2-3 slides, you're going to understand why am I going to show you the lumbar epidural when the talk is on caudal epidural. We shall soon come to it. So you choose the lumbar epidural space. Use the dominant hand for the needle insertion, the non-dominant hand to put a continuous pressure on the plunger of the syringe. And as if the whole assembly goes in, and a beautiful LOR will be elicited, provided you're bang perpendicular to the spine, unless the soft tissue tells you something. And then again, go ahead, thread your catheter. And in neonates and infants, threading the catheter is different and getting the space is different. They are difficult. Okay. Now, why LOR? Well, air is readily available actually, and it cannot be confused to anything else. That's a positive point. But then it can give us patchy blocks, which we don't want. It can give us embolisms, which we don't want. And if you are an ultrasound guided fan, it it is going to sabotage your image. So the transverse section is going to be like this: posterior of the body, anterior of the body. Now come to the area of interest. Now the area of interest is the intrathecal space, and see what happens to the ligamentum flavum and the dura. Look at the story. Concentrate here where the finger is and see what's happening. It will soon tell you what is the ligamentum flavum, and it will soon tell you what is the dura. Okay. Did it tell you what it was? This is the drug. So what came down was the dura, and what remained up was the ligamentum flavum for an epidural. It only needs 2 specialists: those who understand the LOR technique in a baby, and those who understand transverse section of ultrasound in a baby. Why I showed you this was caudal epidural would be of no use if there is no sacrum in the baby, and you do get such cases. So you can go from the lumbar space, and if the work is in the sacral area, you can thread the catheter down. Okay, so this is what you can do when you have such cases, because if the whole block is anchored in the sacrum, and if that itself goes missing, then you need to have alternatives. If it is a unilateral case or a unilateral limb or a limb surgery, go ahead, give sciatic and femoral. If it is an abdominal case, then yes, you can go lumbar or even higher lumbar. But if it is, say, a bilateral ureteric implant where actually the sacral dermatomes are the ones which need to be blocked, then go from lumbar to sacral. So keep that openness of mind so that you know how to use the central neuroaxis once you have understood it very well. This is how typically an absent sacrum presents to you. Well, now where is the future? Future, uh, it's very intriguing in the sense it could be a 3D ultrasound. It's a free sweep taken on a Philip machine. So look at this. It could be something like this. This is the spine, and this is the vertebral column actually, and this is the this one is the dura, and this one is actually the spinal the spinal cord as such. I don't know where this modality is going to take us. We shall keep a watch, and we shall try and work if we get a chance to. But I'm not too sure if Sandeep has logged in. Way back in 2006 or 2005, when we picked up the probe, people did say that this is a fad. I'm not too sure what is there in future. What would 3D and 4D do? But the mind is open, and let's see what it can show us. To conclude, I agree with the first person, Abhishek, and I agree with one part of me which tells me that caudal still is very simple. Caudal can be given by landmark, but there is one part in me which does tell me that what ultrasound offers can never be neglected. So it's still an extremely relevant block. It's a simple technique. It's a valuable tool and a portal for many more things than just a single shot block. So thank you very much for listening to me. I hope this time was well spent, and I hope you could pick up certain thoughts from what I shared with you.
Thank, thank you, Varushali. It was really a comprehensive talk on caudal epidural. And yes, you can stop sharing if you.
Yeah, I will. I will.
Yeah. Or it's okay. Doesn't matter. Okay, that was really amazing talk. Now let's move ahead, and let me just take opportunity to welcome our panelists for today's webinar. Our first panelist for today is a well-known pediatric anesthesiologist from Mumbai, Dr. Dilip Chavan. Sir, can I see him? Oh, yes. You can unmute actually. Our second panelist for today's webinar is our own Dr. Sandeep Diwan. He's our Prac academic director, and I don't have to introduce him. Is he there? Yes, he is there. So welcome. And the third panelist for today's webinar is Dr. Ganesh Boom. I think he's logged in, but I'm not sure because he's still working. So let's start a discussion after two thorough, the basic block and the ultrasound block. It was really amazing. And Dr. Dilip, we would like to hear from you about your take on caudal epidural. Over to you.
First of all, I just want to say is this is the block each and every person as an anesthesiologist, whether he's a practicing as an adult anesthesiologist or a children doing a pediatric anesthesia practice, he has to know this block thoroughly. So this is what I feel, that because there are so many things in pediatric, let me tell you, like almost we are working since last 20 years into this field. This is the one block which has really helped us in giving a good regional anesthesia engine. That is what, and that's why I think so we should know this block thoroughly. As Abhishek and Varushali madam said, that this can be given by all the techniques, and simple way of giving is that landmark technique, which is the best. You don't require anything. The simple, you just need to learn the landmark techniques and do the procedure. 5 to 10 blocks, if you learn from the experts, then I think so you are able to do this procedure. And you can get away, because most of our superficial surgeries, hernia, orthopexies, and even lower limb surgeries, what we do is we do it with a caudal. There are some other techniques, like for example, if osteotomies and other things are there, we can add the caudal catheters, but the simple way of doing with a simple caudal block, you can get away and make your patient pain-free post-operatively too.
Good. Thank you, sir. It was really wonderful listening to you. Can we have Dr. Sandeep? Sandeep, sir, are you there?
Hello.
Sandeep, sir, your take on caudal epidural. You want to add
Yeah.
something about the crown?
I have, there were good lectures, basic by Dr. Abhishek, and then the advanced one by Dr. Varushali. So this is basically a question to Varushali. Can you hear me, Varushali? Is she there?
I can.
Yes.
Can you unmute yourself?
Varushali, we can't hear you.
Yes, I can.
Yes.
So you mentioned that when by using neurostimulating needle, when you insert the needle through the caudal canal, and suppose if you perforate the dura, and your needle is just inside the dura and not near the spinal cord, because the spinal cord ends higher up, and lower down will be the rootlets. So if you simulate it around maybe 3 milliamperes, what you mentioned, will the contractions at that point, and if you advance the needle still further close to the spinal cord at the conus medullaris, will the contractions will be the same or they will be different?
All right, for the question. Okay. Now, first of all, conus medullaris as such is going to be really higher up. So to reach conus medullaris through the PNS needle, you will have to try very hard. You may still might not go. But if you are in the CSF through the dural sac, I think it's going to be the same. This is what my thought process is. The answer to your question is I'm not too sure what kind of contractions will I get at what milliamperes if I'm in the conus, near the conus. I'm not too sure.
Because you mentioned that at some in some cases you have seen the dura lower down. I mean the spinal cord coming low down. In one of your slides, you have already shown that it might come low down up to the level of S3, S4 at times.
Ideally, it should not make any difference because first of all, even if I am at the level of spinal cord, it is going to be the CSF that is going to conduct the current, which won't take much to conduct the current. So it has to be at the lowest possible current that I shall get very vigorous contractions, in fact. Okay. And everything starts contracting, you know, Sandeep. What I have seen is just the anal sphincter doesn't contract. The lower extremity, every joint starts contracting when you're right in the CSF. So that's something that I have observed.
So that it means it's a diffuse. Those are diffuse contractions.
Yes, all over. Yeah.
Okay. The second one is needle if it's placed on the ventral aspect and placed on the dorsal aspect in the caudal epidural space, with the concentration remaining the same, 0.2% ropivacaine. Did you find any difference in the motor and sensory outcomes?
Okay, I think your question is stemming from the fact that on the anterior aspect is the motor part and on the posterior aspect is the sensory part. So I can see what you're thinking of. But then in the caudals, being caudals in very small babies, the diffusion of the drug happens right in front of you. So if the injection is happening right in front in the anterior epidural space, you will see after a fraction of a second, the posterior dura also sinking down. So it's kind of, it's not a watertight compartment at all.
The third question would be, in how many patients you keep ultrasound? Why are you smiling there anyways?
This is like an MD Viva. I am sweating.
More than that.
Yeah, please ask. No, it's interesting to answer you. Please tell me.
So in how many percent of or incidents in your case, you keep an ultrasound probe on the caudal, on the top of the caudal epidural space, and you say that I'm not going to give caudal in this case? Has it happened any times?
Yeah, it happens. It happens because there would be surprises when, you know, when we do PACs in children. I'm going to be very frank when I talk to you.
Yeah.
When we do PACs of a baby, I don't know how many times we really turn them and see their sacral area where we want to give a caudal, because they're very irritable or something like something deters us from doing it. I'm sure Dilip will also agree. We'll put a stetho, we'll do many other things, but we may not go to their spine. And in the OT, while we've tied a mask or put in a tube and we make them caudal, there is a tuft of hair, or there is some dimple, or there is some discoloration, and it's not very, I mean, it's not uncommon. At the same time, it's not once a week. But I think once or twice a month, yes, we do see such things.
So do you always see for the pulsations of the cord? Because that is one thing which matters. When you don't see any pulsation of the cord, it might reveal that it could be a case of tethering cord in this case. So have you come across such kind of cases?
pulsations of the cords as such, I haven't made always an emphatic point to see to it that I see the pulsations of the cords all the time. But most of the time they are there. Even if the cords are tethered, I have seen that there is a transmitted pulsation there as well. It's not totally absent. I don't think they're totally absent. I have seen pulsations there.
Okay.
But then I have gone to some other way of giving a block. I've gone peripheral.
So you have been working a lot on this caudal epidural because I have been seeing you, performing the landmark guided, the neurostimulation, as well as the ultrasound guided, all in the workshops, almost everything. And it's a pleasure to see you doing that block actually.
Thank you.
No. So
you and Bharti made a kind of communication with each other, and I shall flatter her at the end, beginning, and you shall flatter me later on.
No, it's nothing of that sort. It comes very naturally from all of us.
Thank you.
So the other question that comes to my mind is that you mentioned that the catheter going from the dorsal aspect to the ventral aspect. Now, don't you think that it's a kind of, a dangerous move for the catheter going from the dorsal to the ventral aspect? If it gets stuck up or if it gets coiled, if it gets knotted along the motor nerve roots particularly. And we don't use the neurostimulation as well. We just use the plain ultrasound catheters, and these are non-stellated ones. So I think it would be, that would be one thing where I would not go ahead if the catheter moves from the dorsal to the ventral aspect. I think it would be a red flag for me not to introduce the catheter still more further. It's what is my take on this, because I have not come across anything in the literature as such. What would be your opinion?
Well, I do understand your concern, and I know it's extremely logical. What you said is so logical. I would also put in a word here that when you start putting the needle first through the caudal space, and if it goes a little more inside after the give of the sacrococcygeal membrane, it's very somehow likely that the catheter would also go more on the anterior aspect. And if you stop immediately after the give of the sacrococcygeal membrane, then it's very unlikely that the catheter would go on the anterior, and it will go more on the posterior. Well, on its way also we have seen it, but we could withdraw a little and go ahead again, but we've not been able to really do much with the course of the catheters. If you say that it is going to strangle the spinal cord as such, because the catheter is going up and coming down, going down and going up again, it's going to strangulate the cord. Highly unlikely. Luckily, I haven't seen it, because the space is very gelatinous and it's very wide, and it becomes wide rather because we are also going to inject the drug. And we remove it in 48 hours, and we haven't at least yet come across it. Now that you have told me, I'll become paranoid.
No, it's not it's not something.
No, it's possible. It's possible.
So it's just a fear that I had in my mind when I used to use catheters for thoracotomies under ultrasound, and I used to see the catheters going from dorsal to ventral. I used to think that I think it's a dangerous move for the catheter as well as for me.
I understand.
So one last question, if you don't mind, Varushali.
Please. I'm loving it.
If I ask one last question?
Yes, please. Yes.
Okay. So the role of ultrasound, as we mentioned about the volumes of local anesthetic use, has gone down in peripheral nerve blocks. In the neuroaxial blocks, do you use the same volume, or you see the spread of the local anesthetic cephalad, and then you stop if you have reached at that certain point?
Yes. And
can you challenge the whose law it is? I think it is Armitage's formula.
Yes.
Yeah. So Abhishek, I am right?
Yes.
Yeah. So can you challenge the Armitage law? Formula with the ultrasound.
Maybe.
Does Prac keep any prizes for best questions? No, this is a wonderful question. Sandeep, I've already thought a lot on it. I tried to challenge that fellow, but he's
Mhm.
unchallenged. You
Mhm.
need that volume. Trust me,
Yeah.
you need that volume. And
Okay.
where you could really decrease the volume is in the continuous catheters. Go
Mhm.
see to it that the tip is there if you can. If you can't, see to it that the drug, pushes the dura down a little. So you can definitely reduce volumes in continuous, but not in single shots. In fact,
Okay.
sometimes I have taken 1 ml of normal saline and injected to see to it that after T10 it has gone.
Mhm.
So I don't think that I could challenge him. No, I couldn't.
Mhm.
I
Okay.
agreed with him. I agreed
Mhm.
with him when I started following the drugs.
Uh-huh.
Yeah. And also, Sandeep, one more thing is, suppose if you have injected and you have not seen it till T10, you don't
Mhm.
know. After maybe 3-4 minutes, it might seep up also. So
Could be.
yeah,
Mhm.
so these are all such interesting aspects, and we need to find answers. But then we'll have to stop the surgical procedure from being started. After 5 minutes, again go at the same level scan, and then introduce some more drug if you wish to. By that time, maybe you've exhausted your local anesthetic in very small babies. I'm not too sure.
Okay.
Can
So
I,
that, yeah, that's all from me. Thank you so much, Varushali.
Thank,
Yeah,
thank you.
and in fact, one more thing that just cropped up in my mind while you were asking me these questions was, there is another beautiful thing that one can do with caudals. When you're
Mm.
injecting, there is a possibility that you can increase the pressure inside the CSF itself. And that actually can be projected in the optic nerves. And we can
Okay.
see the optic nerve diameter before giving a caudal, especially in small babies, and after giving a caudal. I think Dr. Lee has worked on this.
Okay.
So that's
So,
another aspect.
does it? Do they mention the efficacy of block with the pre and
Sorry?
post optic? Do they mention the efficacy of block
No, they
pre and
haven't
post
correlated with the efficacy. They have correlated with the volume used, I think.
volumes? Okay, I see.
Yeah.
Mm.
can I ask you one or two stupid questions maybe? Does the speed of injection matter here when you are injecting the drug, whether the faster, I mean, any take on
It's
that?
spinal.
Yeah,
Yeah,
unlike spinal in caudals, the speed has not done anything much to the spread. We feel that it would propel the drug a little more because of the speed at which you will inject. It doesn't happen. And secondly, I think the basic nature of we giving the drug in small volumes in
right.
aliquots will not let us do that.
True.
So, Bharti, it was a sensible question. I kind of thought,
Uh,
I know what you thought before you asked me this question.
I know. Second thing is, since you have been doing lots of catheters, and as you have told that the catheter has its own path, any incidence of knotting or see, all this catheterization is done with patient under anesthesia, so there is no pain of during introduction of the catheter. So any incidence of pain when you are taking the catheter out or knotting or something like that.
Surprisingly, not in neonates, but this has happened to me maybe once or twice in older children. While removing the catheter, they really are in agony, but not during the infusion is on. Maybe at that time we just kind of tickle some nerve root and come out. I'm not too sure.
Correct. So
Yeah.
what do you do?
Okay.
How do you deal with this?
When they really start, it would be a sudden sharp sound coming from them, a screech coming
Correct.
from them, while so we stop, and then we make them lie down if they're not in a spica, and then we make them lie down in the position in which the epidural was given, and very gently take it out.
Any role of again injecting some saline or something and
Yeah, they say there is, but luckily we've not come across them too many times, and they just come out. I mean, I know I'm speaking arbitrary, but this
yeah, I
has,
mean these are the questions which come
yeah,
because the
I know,
patients
I
are
know.
under anesthesia.
Yeah, I know.
And
Dilip, you would agree with me, don't you? With neonate continuous catheters, you just have to pull it very easily, comes out in our hands. maybe in grown-ups, one or two incidences I remember, it's in grown-ups.
Yeah.
One of my colleague had encountered with a problem with the catheter, got stuck.
Okay.
So then she called me that it is not getting out. So what need to be done? So I thought that time that when I saw that child and then try to little bit remove, um,
Pull it out.
pull it out, but it was very difficult. So one thing what then again what we decided that we should take that child again under inhalational agent or CO fluorine, so it might get relaxed, and because of that we could again pull out. So that was one thing what method we tried in this child, and then it was easily removed. Otherwise final decision was like little bit incision, called the surgeon, spine surgeon, and then but then we thought that little we make relaxed little spine through the inhalational agent, and then I think so that technique got successful, and then we would remove the catheter.
Philip, at what level the catheter had got stuck up in that case?
Yeah,
No, at what level the catheter had got stuck up?
it was lumbar level, I think so, L1, L2.
No, but it was inside the spinal cord, or I mean, inside the intra-epidural space or outside the epidural space?
So it was inside the epidural space. So it was totally almost around 6-7 centimeter catheter was used.
No, you mentioned that CO fluorine did relax, but what did it relax? The muscles around the back, if the catheter can be easily pulled out.
We just thought we can some sort of technique what we can relax the back and then we can do it. So that was what the intention behind doing that.
Okay.
What he says makes a lot of sense, because your paravertebral muscles are relaxed. The ligamentum flavum may also be kind of, it doesn't have its own tone, but it's a ligament. It may just give in.
Yeah, I agree with him. What he has used the technique, but it means that the catheter was more in the grip of the paravertebral muscles.
Yes.
Yeah, rather than in the in the epidural space.
Yeah.
One more query. You have talked about absent sacrum patients, the children. And you mentioned that you put the catheter in the lumbar area and then direct the needle, the catheter is directed caudally. So can you see the dural sac or something under ultrasound when you are doing this procedure, or is it just a blind epidural catheters? Do you have anything on that?
Yeah, I wish if you really see those 3 cases that we have written
Yes.
in the International Pediatric Journal.
Yes, I see.
Yeah, the one which had an epidural placed at that time, ultrasound was not in vogue, and we have an X-ray of that.
Yes, I saw that. There is nothing.
Ultrasound. Yeah, we didn't have an ultrasound. Otherwise, I would have put the image of that there.
Yes.
So what we could have now as an afterthought we could have done is, and we could have done an MRI of that baby, and we could have seen really what's happening to the cords. But then at that time, what we had thought was, let us go in with the catheter. Let us not push it in too much, or let us stop if we have any resistances, and then let us see what the effect is like.
Yeah. It was very interesting.
But what you are saying is absolutely right, and it's written in the discussion there that we must be documenting what's happening inside to the cord before going ahead and doing something in it.
Correct.
I think Varushali, the direction of the catheter downwards corded in patients with sacral urgenesis, because anyways it would be very easy block, because the cords are clumped, the end of the cord and it's the phylum terminal, they are all clumped together at that point, at that particular point. So from there they exit. So it would be very easy to insert the catheter from cephala to caudate and obtain a complete anesthesia. But I'm still doubtful about the neurological sequel it might have in the post block period. I'm
Exactly.
really sure about it because
Yeah.
you're going to give I know what concentration of local anesthetic and how much infusion in that particular area where all the neurological elements are concentrated at one single point.
Yeah,
So
I
really
do agree.
doing this
Uh,
particular technique. In fact, usually what I would say is in sacral agenesis, in one of the patients which we did recently, we in fact gave a sacral ESP block rather than going in for the central neuraxial blocks.
all right.
That would be more helpful. The ESP, a lumbar ESP or maybe a sacral ESP, that would be more helpful.
Yeah. Actually,
Yeah, and in one of the, I have done few contrast study cases, and with the sacral ESP, we have seen the drug going into the sacral plexus from the dorsal foramen into the sacral plexus. But yeah, but in this case, you need to give a high lumbar ESP, and because nevertheless the sacrum doesn't exist, but the muscles around that will be existing. So you might have to give a lumbosacral ESP in that case.
see what happens in very small babies for ESPs. Well, not that it cannot be done, but we need bilateral catheters.
Correct.
Yeah.
So the dose adjustments doesn't become that easy. And
Hmm.
to manage one catheter in a baby itself is something.
Yeah.
Again, manage two will be double the trouble.
Correct. Correct.
Number one. Number two, then the ESPs were not known to us.
Yes.
Yeah. Number three, we just had one clinical judgment that if the insertion of the catheter gives us resistance, we are going to abandon the procedure. Yeah.
Right. Right.
These were the three things. And then there was one, Sethna had done 2 or 3 cases long back, and I had found that in his literature. I mean, in his cases, he too had published 2 cases of that kind, and he said that it could be done, and he had done it in a very similar way that we did, and that probably encouraged me to do it. But
Hmm.
I agree with every concern which you have, Bharti, and you and Bharti have put up.
Hmm.
There is one question from from Sandeep Mutha. If there is a dimple at the level of caudal injection where we put the needle in, then do you go ahead or what do you do?
If there is only a dimple and if we have an ultrasound scan, it's very interesting to see what is underneath. And many a times what I have seen, Sandeep, is that dimple is only in the skin and the subcutaneous space, and the below the bone everything is normal. In that case, go ahead.
Okay. If there is a tuft of hair, then what do you do?
A tuft of hair is a graver sign. Tuft of hair means that there is something happening underneath and the cord is not correct. I think
Hmm.
leave alone. Leave the central neuroaxis alone and go to a peripheral block if you can.
Okay.
Hmm.
Another thing is if the patient has neurofibromatosis, you see the coffin-led spots, do you still go in and do the caudals?
I would rather avoid.
Dr. Dilip, your take on this?
It's not an issue with doing a caudal block.
You can still go ahead. Or would you do it with ultrasound or?
So with the ultrasound, nowadays we do everything with the ultrasound.
Yes.
It is always better.
Yeah, of course. But if you don't have the ultrasound, will you stop there or what? Without ultrasound, should you venture into this? Abhishek?
No, without ultrasound means I personally would not go for. That's what I think. You don't know what lies beneath.
Exactly.
Yeah, in today's day and age, we wouldn't.
Yes. Yes. Anyone else wants to ask any questions?
I think you have covered almost everything.
Yeah.
Hmm.
That's true.
Vishal,
I never
Okay,
thought
Sandeep,
Caudal Epidural will have so much of discussion, but it is really wonderful.
Sandeep, do I pass? Do I pass? I get a pass.
Don't see. You are the
One more
president.
question.
You are the president.
Hello, Varushali.
Yes.
Hello.
Sandeep, go ahead.
We can hear you,
Yeah,
Sandeep.
yeah. Initially, when we used to do PDA ligation with the thoracotomy in babies, that time the catheters were not there. We used to give caudal epidural 1 ml per kg of the drug. And it used to give a very good thoracic analgesia. Any take on this? Why the drug spread is still the thoracic level or beyond it?
Your babies are really small, aren't they?
Yeah, babies are really
So
small.
that is why it has
So
spread.
it used to be 8 ml or 6 ml or 10 ml maximum dose it was
Yeah.
going.
Yeah. I think the spine, I mean, the epidural in babies who have never walked, don't have any curves in their spine at any level. It's a straight walk for the drug to go in. As we just discussed, that maybe at that given point, maybe it's still T10, but later when we make the child supine, maybe it can trickle up even further by the pulsations of the cords, because cord finally is a pulsatile structure. It might propel the drug a little ahead. So I totally agree with you. It can reach high up. And we have done it. I mean, we too
Yeah,
have done our thoracic work, and I mean, I totally agree with you. It can happen.
Yeah,
one more question. If there is a knotting of the catheter, if you have put the catheter too much inside,
yes.
can you hear me? Yeah, if
Yes,
you have put the
yes,
catheter too much inside and there is a
yes.
knotting of the catheter, how do you remove it?
I think Dilip has told this, no?
Yes.
Yeah.
Sandeep sir,
But
we
how to
Number
remove that
one,
catheter?
okay. Number
It
one,
can break.
you may really not. You may when it is inside the body, you may not be able to really untie the
Untie
knot
the
as such, obviously. So you have only two choices. How are we so sure that it is knotting and not just abutting some against something? It could be even that. So first is get the baby a little relaxed and try to remove it in a position in which it was introduced. It just gets easier because the space
Yeah.
will open up. That's the same concept which Dilip is discussing. Like, you take them under anesthesia and then remove it.
Can I just show one this thing video if it's possible?
Yeah.
yes, please.
Yeah.
Please.
So this is I think if this works, this will help in uh, answering his question. Who? Sandeep's questions. Yeah, Sandeep's questions. 1 minute. Let me see if it works. If it works, then it's okay. Otherwise, it's
Otherwise, you can describe to him what you want to say.
yeah. Anyway, he's going to meet me tomorrow. So that 1 ml per kg, what you said, dose that does reach the level of very high up to the thoracic level. Yes, we have seen that couple of times. So that's why we started using even lower doses when we gave this caudal epidural. Anyway, it doesn't work. So I will show it to you tomorrow. No, not an issue at all.
Okay. Opening? No, it's not opening.
Let me see. It should, I think. Just give a.
Yes.
See, it has reached up to that level. So when I pinch the triceps, it is at that point. So it has reached up to the level of C6, and this was just a colostomy. That was a long time back, of course. So it does reach that level.
One more question. Once we were doing a caudal epidural for pain management, that was under Siam and ultrasound guided. So we put the needle inside and did the aspiration. Aspiration was negative. The needle was in proper space. But when we injected the drug, it was intravascular. There was no blood which is coming out, but it went intravascular. So can this happen if you are giving a blind puncture or even caudal epidural under ultrasound where you are not using a dye?
All possibility that it can happen, and hence our rules of going with aliquots, going very slow, seeing to it that the ECG is on and the SPOs is functioning. I agree with you. It can happen. And we do not have the dye which pain management people have. In a jiffy, they will show the plethora, which is, which takes up the dye and suddenly disappears when it's in the intravascular compartment. We don't have
Yeah.
that luxury, but it can happen with us.
But the sacral venous plexus has got a maximum concentration at the level of S4. So you need to be very careful when you insert a needle. You wait for some time and don't inject immediately. Let the blood come at the hub in case if it has to. Then you can inject.
Yes.
I think we can wind up. Varushali seems to be very tired answering all the questions.
Not at all.
Yes.
No,
But
not at
before we conclude, I must I must let me thank all our speakers. Varushali especially, she has taken so much time and really given a wonderful presentation. Same with Dr. Abhishek Lonikar. He has been working throughout the day and still, I mean, it was really wonderful, Abhishek.
Thank you, ma'am.
It was a very good presentation and you touched
Yes.
all the basics.
Yes.
And before I move, let me thank all our panelists, Dr. Dilip, for taking time out. And we want you to join our Prac webinars. You will be on that WhatsApp group and you can join for all our webinars because the Zoom link will be shared. And we would like you to give your inputs. And thank you, Dr. Sandeep Devant. Already gone? No, he's there. And Dr. Ganesh and all our team members of Sanchiti and Prac. And we are definitely grateful to Dr. Parag Sanchiti, who is our chairman and the medical director, for providing this platform to us. And yes, we are also grateful to Dr. Ashok Sham and Mr. Rahul Chaube for all the technical help they gave us. Without them, this was just not possible. And last, but the most important, we thank all the delegates for who have joined us on various platforms for our patient hearing. And thank you all.
Thank you, ma'am.
Good night.